I was asked to talk about non-surgical or non-radiation approaches. That simply means that we have to give medications that will reach the blood and then will circulate throughout the body. That means obviously patient has a high risk situation because we're treating the whole body. The other thing is that for many, many years, we've been treating all patients with similar treatments. We still do it. But gastric cancer in every patient is a little bit different because it develops in the context of your own genome that you get from your mom and dad. So my genome is different than anybody in this room. And if I get stomach cancer or any other cancer, it will be in that context. So we have to get there. We have to be able to take a sample of the blood for the genes that you get from your mom and dad, to look at the sequences there, and also take a sample from the tumor and be able to say what particular treatment could be effective for a given individual patient. But that's not what we have been doing. We have become an expert in just staging the patient. Just stage the patient. Once you determine a certain stage, then you already know from your training and from your experience what treatment will be given to every one of those patients in that stage. And because of that, we haven't really made much progress, unfortunately. So I want to show you some examples. This topic was brought up to show you some examples of what kind of patient population is being diagnosed. And this is in most of the world, just not in the United States. So here we have a patient with newly diagnosed gastric cancer. It's a very large cancer, which is shown with the golden and silver color on a PET CT scan. And it gets worse. So this is a patient who could potentially be treated with surgery or radiation and chemotherapy. We call it combined modality therapy. And if they're treated at a high volume center, the centers of excellence, then there's a high cure rate for this group of patients. So one message I have is whenever there is a potentially curable situation that you must ask your doctor whether this is really curable or not. If that's the case, then you should entertain the possibility of going to what we call high volume center. And that's not because the individuals at high volume center are smarter than individuals at lower volume center, but they have more experience. And all of you know that experience is very important in terms of delivering or achieving certain goals. I'm going to show you another case. This is a little difficult to see, but on your left, you can see just by looking at this skeleton that this is a very young person. And this patient, at the time of first evaluation, already had cancer in the liver, a lot of lymph nodes. I don't know, I have a pointer. I don't think I can point.
There's a pointer there on the bottom.
But I don't think I can point to their screen. It's going to be tough. So anyway, the point is that this young man came in with minimum symptoms and has been avoiding them, as most patients usually do. And when they go to their PCP, the private or the personal physicians, family physicians will also delay making the judgment that it may be a serious problem. And then you have this extensive cancer. So these are the data from our national registry for all gastric patients. These are thousands of patients treated across the nation, and only 29 out of 100 people survive. So these are all comers. Anybody who's diagnosed with stomach cancer, their chance of surviving is only 29%. And then if you stage them, then the survival depends on the stage. But as a whole, if you think about gastric cancer as a health burden, it's a big problem. And as previously mentioned, if you diagnose 25,000 new cases, about 11, 12,000 patients die from that every year. So when we talk about systemic treatment, and as I mentioned, that means high-risk situation, the even 2-year survival is very limited, is 30%. And 5-year survival, like Debbie and others, is very unusual. So we have a paper that will be published where we had more than 250 patients with metastatic disease just recently treated. And then, so the point I want to make is even if somebody has metastatic disease, we can use radiation in some patients, and we can use even surgery in some patients. So we have to select out certain patients whose cancer is very sensitive to chemotherapy that we give. So when you give the same chemotherapy to 10 different patients, one of them or two of them will have a dramatic reduction in their cancer. So we have to select out those patients that could take advantage of radiation and chemotherapy. So in this paper that hopefully will be published in the next several months, and you'll be able to review it, there are approximately 40 patients who came in it, all of them came with stage 4, but these patients were able to get radiation and surgery and survive beyond 3 years, and hopefully they will survive very long time. So there is a cure fraction with metastatic disease, so that is one hopeful thing. But again, as I mentioned, you have to be treated at a high volume center. People who have a lot of experience and seeing this kind of patients over and over and over, not just one doctor, but the whole team. And the whole team is communicating regularly. Like at my center, we have a gastric cancer conference every week. And there are at least 20 people in the room. We have visiting scientists coming in and sitting there, people with a lot of experience from other countries. And they will say, I will do this, instead of one of the other person will say, I'll do this. And we develop a consensus. And there are radiologists and pathologists. So people who can help you critically need to be there. So it's not enough that you end up seeing a radiation doctor in the clinic, then the next clinic you see a surgeon, the next clinic you see a medical oncologist. And even those 3 people are talking to each other, that is not enough. What we need is the expertise in the given institution. So there may be 20 people who are experts in gastric cancer. Well, all 20 people are not going to see that patient. But by doing this kind of conference, you can take advantage of the expertise of all 20 people, and the patient benefits from that. And that can only happen in centers where patients are being seen over and over again. So I'm not going to go on and on. I think the message is that we have to do a lot more research because of these very poor statistics. And surely some patients can survive very long time. But what about the rest? The rest are tremendously disappointed. Families are disappointed. They suffer from side effects of our treatments and actually don't benefit from them. And we have to change that approach altogether. So on this slide, you will see there are 3 drugs listed in yellow. And unfortunately, in the past 35 years, only 3 drugs have been approved for treatment of gastric cancer. We have a couple of other drugs that are grandfathered in, but only these 3 drugs have shown some survival advantage. And ramucirumab, for example, has shown some survival advantage, but I don't recommend you receive ramucirumab by itself unless it's in a clinical trial, because by itself, it's almost a useless drug. It should be combined with another drug called Taxol. The second drug there is trastuzumab that Debbie and many others have been on. So you always ask about the HER2, but there should perhaps be additional testing of the tumor, even though at the moment doing genetic testing does not really yield new treatments. Right now, it doesn't. But when we do a more specific type of testing, more extensive testing of the tumor and maybe blood, because there are a lot of tumor molecules are circulating in the blood. And when the technology gets more sophisticated, we can just take a sample of the blood and figure out what treatment, what targets exist, and then either develop the drug or use the drugs that are already there. So future seems like promising, but the pace at which we are making the progress is really unacceptable. So I'll give you an example. For lung cancer in the past 5 years, there have been at least 6, 7 new drugs. For melanoma, there have been at least 5, 6 drugs. But for gastric cancer, there has only been 1 drug, which is ramucirumab, which is just a borderline agent. So I think we have to make a lot of noise, and Debbie's Dream Foundation is already making that noise. So we are listed in Department of Defense funding, as you've been told, and hopefully NCI will set aside some money for dedicated money, like they have for pancreas cancer, for hepatocellular carcinoma, for colon cancer, but not for gastric or esophageal cancer. So we need that. Then we need, as I was mentioning to one of the gentlemen earlier, that companies like Foundation One or Celera, they already have huge amount of data because we've been sending samples to them for analysis. And they charge you for that. They are a profit-making organization. There's nothing wrong with that. But they have huge amount of data on gastric cancer. And they need to donate that data to big institutions where there are expertise to analyze their data. So we can make much rapid progress through the data that already exists. We don't even have to ask them for any money. So that's one way. And the federal funding is really not increasing. So I think we have to rely on public to make the donation. Like Bernie Sanders made $50 million from public donation in 1 month. And these are not big corporations donating. These are individual people. The average donation he received was $27. So I think if we galvanize the public, we can raise a lot of funds and help a lot of young investigators. Thank you very much.
Thank you, Dr. Ajani. Does anybody have any questions? Please, up here in the front. Please go ahead. The microphone's working now.
Doctor, yes, I'm certainly with you when I say run, don't walk to your nearest high treatment cancer center if you're diagnosed. But are you tracking those that go to a high treatment cancer center versus those that don't, and then come up with survival rates against the general average?
No, we are not. We're tracking all our patients. So the publication that I mentioned to you is based on our database. So every patient that's coming in to my institution goes into a database, and we develop. But this is an important point. We have data on surgery. So surgery of stomach cancer and esophageal cancer, pancreatic cancer, there are data in huge number of patients based on the high volume surgeon and high volume institution. So you get less complications at a high volume institution compared to low volume, and your survival is better. So this is already published. We don't have data on chemotherapy, for example. So sometimes asking the patient to go to high volume center with an so-called incurable disease may not be justifiable, okay? So we understand that. But the high volume really teaches you things that you just can't learn. If I see some type of tumor once in 3 months, I'm not the person to ask what to do about that. So that's the point I want to make.
One last question. Once someone has gone through treatment and has been without symptoms or any reoccurrence, let's say for 2 or 3 years, when should the continued monitoring or looking through PET scans and CAT scans cease?
Very good question, actually. So this is not in the area that I was asked to talk about today, but we have published information on this, so, and there will be additional information to be published. So once you have a potentially curable condition, and you deliver a curative treatment, and patient becomes what is called NED, no evidence of disease, then normally what happens is those patients are followed periodically. But the so-called surveillance enterprise is very expensive, cost-wise and emotionally, and the yield is very low. So there are publications from us and others saying that we don't really need to do so many tests. Like the PET scan, there was a paper published recently saying if you do PET scans in follow-up compared to CT scan, the survival of these patients is similar. So that's an area where a lot of empiricism is being used. It's not based on data. So next time when I tell the patient, come back in 6 months, it's really, I'm just guessing. It's not based on data yet.
Another question up front here?
Yes, Doctor. I've been told that 80% of GAC diagnoses are already at stage 4. And we know what the survival rates are of stage 4. So my question is this: what is the state of the art for early detection of GAC? For example, blood markers or biomarkers?
So as someone already mentioned, that in Japan and in Korea, they have figured out the high-risk population, and then they screen them. We cannot really do that in this country because the incidence is low, and the population at risk, so-called, would be very high. So we don't have the resource. We don't even have enough gastroenterologists to, for example, scope me every year. We don't have that. So I think the promise is what you just said, is the blood test. Everybody can have a blood test. And in the future, we could develop a test not for gastric cancer, but for cancer itself. And people are working on it. So, I get my cholesterol checked, but the blood can be tested for abnormal genes that I shouldn't be having. It can only come from cancer. So I think that's the promise we have.
Christy, go ahead.
Is that on? Okay.
Yeah.
I'm not sure if this is your area or another, so forgive me. Can you talk about immunotherapy since that's the latest breakthrough?
So that, I think Dr. Ilsen is going to talk about, but I can just mention that, immunotherapy is the best promise we have because our immune system already has the tools to kill the cancer. The reason it doesn't seem to kill the cancer, there's inhibition because the cancer looks very similar to our normal tissue. Okay, most of the cancer is similar to normal. So immune system is very good about detecting virus sequences because they're so different than ours, bacteria and fungus. But when it comes to our own tissue-like abnormalities, it doesn't. So Dr. Ilsen and maybe Dr. Bass will explain to you how we can tweak the immune system to unleash the tools it already has. We don't have to teach it how to kill. We just have to tell it to kill. And I think this will happen. It will take a long time. Current medications are barely effective.
Doctor, how can we find these high-volume centers in the area where we live?
I'm sorry, I missed that.
How can we find the high-volume cancer centers in the areas in which we live?
So I don't know this, but there are, you just go to the NCI site, and there are what is called the NCI designated comprehensive cancer centers. So these are just cancer centers that are treating only cancer patients, and they have to achieve certain capabilities for NCI designation. So that's the way to do it, I think.
I'm going to take one more question because we have to move on. Please, in the back of the room.
So I'm coming from Alaska, and a lot of the people in Alaska aren't able to financially go to the high volume centers. Do you have any opportunities to work with doctors outside of these high volume centers and try to provide therapies for their patients that are, you know, front of the line therapies that they may not be able to get, or you know what I mean, just trying to figure out a way to get those therapies that are working for patients at the high volume centers to the more local centers so that other patients could possibly partake in those therapies as well?
I think that's a very good question, because the gastric cancer conference and esophageal cancer conference, these are two separate ones at MD Anderson. We do it once a week. So the patients are not there. So I think what you just mentioned is a phenomenal possibility that you can do telemedicine. You know, for our group, for example, you can present the case from Alaska, show us all the things that we need, and we can, you know, help you decide what to do.
We actually do telemedicine all the time because most of our cancer patients are in far distances. They are in other regions of Alaska, and everybody knows that Alaska is extremely large. So we use telemedicine all the time. So that's definitely something that we would be considered, you know, using.
Yeah, great. Thank you.